Hello, everyone, and welcome to Grand Rounds. A special warm welcome to our colleague at UCLA, Dr. John Mafi. He's going to take us on a healthcare ride in value-based care. Also, welcome to our chief of department and all the faculty and residents and medical students. A few words about your distinguished career, John Mafi, before we let you on. You are an associate professor of medicine at the David Geffen School of Medicine at UCLA. There, he teaches and practices primary care at the Federal Quality Health Center and also works as a teaching attending at the UCLA Geriatric Service. In addition to this, he's an affiliate adjunct physician policy researcher at the RAND Corporation. Before joining UCLA in 2015, Dr. Mafi was a chief medical resident for a year, followed by a 2-year stint as a general internal medicine fellow at both Harvard Medical School and Beth Israel Medical Center. He was also earning his MPH at the Harvard Chan School of Public Health during this time. Dr. Mafi's main research interest focuses on the intersection between health care value, policy, and aging. Over the years at UCLA, he's managed to secure NIH funding as a principal investigator, earning notable grants such as the NIA R01 Award and the K76 Beeson Emerging Leaders Career Development Award in aging. His work aims to tackle the issue of harmful low-value care among older Americans. More recently, Dr. Mafi research efforts have been backed by grant funding supported from Arnold Ventures and the Commonwealth Fund. This support fuels his studies that explores the impact of COVID-19 policies on healthcare access, value, and equity. It's with great pleasure, GIM, as the interim chief, I am allowed to welcome you to Grand Rounds today. And in the future, we hope you will accept the position at GIM. I haven't gotten you there yet, but I'm still hoping. So welcome.
Thank you, Atar, for the very kind introduction. And thank you, Allison, as well, for just a wonderful stay. We've just had an amazing time here, felt very welcomed, and had some really fun talks earlier this morning. So I'm going to be talking about achieving healthcare value in our time. It's a big topic, and I'm really excited to talk to you about it. We can make it go forward. So there we go. Thank you. Yeah, so just some disclosures on my funding. So the funding for this work was a CTSI Career Development Award, which is kind of like a bridge career development award until I could get my NIH Career Development Award through the National Institute on Aging. I've gotten other grants from some foundational grants, and I've gotten some non-financial support from Milliman MedInsight for research. And I've also provided unpaid consulting to MedInsight and to AHRQ, the Agency for Healthcare Quality and Research, but I don't have any relevant financial conflicts of interest other than the grants. So I want to start from a real case from the wards. I have lots of cases from the wards on the harms of what we call low value care. And I want to present you with this patient. He was an avid scuba diver, and he presented with a complaint of clicking in the ears. And he actually had a trusted private ENT physician as their family ENT physician, and the ENT physician ordered a CT scan that was sort of negative in the workup for the clicking of the ears, but incidentally there was a nasopharyngeal nodule that was seen. It was asymptomatic and it appeared benign based on the imaging report, but the ENT physician strongly recommended a biopsy. Unfortunately, the biopsy led to some hemoptysis, and there were some delays in addressing the hemoptysis, and then that led to aspiration pneumonitis. And then that pneumonitis unfortunately developed into acute respiratory distress syndrome, ARDS, and the patient went into respiratory failure and shock and ended up being in the ICU for several months. There was a $2 million hospital bill. They had to pay 6 figures out of pocket. It was a disaster. Unfortunately, the patient ultimately required a lung transplant because of the damage to the lung, all because of the adverse event related to the biopsy, which, by the way, was ultimately a benign biopsy. And I show this case because it really, as a primary care physician, as a general internist, I do see in my practice, unfortunately, stories like this where patients are inadvertently harmed. Sometimes, often it's very, very well-meaning, but there's harm associated with some of the interventions that we don't foresee. And in this case, this was a biopsy on a benign appearing asymptomatic incidentalloma, which we're seeing more and more these days, that led to a clear cascade of harmful consequences for this patient. This was, of course, an extreme case. This is a rare sort of black swan event case, but at the same time, there are mundane harms that happen every day in medicine. In any given ER, you walk into the ER and you'll see a patient who's admitted for an antibiotic-associated adverse effect, diarrhea, a rash. Often these antibiotics most commonly are prescribed for upper respiratory infections that provide no benefit. So these are more mundane harms that happen every day, and it's preventing this patient harm that is the moral framework for this whole field of work. This is why you should care about the idea of inappropriate or low value care, because of the direct patient harm. And that's not just physical harm, but it's also financial harm, because often patients are increasingly paying the full price of care when they're entering into high deductible plans. So this is a really important issue, and that's why it matters. And I think it's really important to be clear on that. But, there were a lot of cases that I saw as a resident, but to make a difference, you really needed more than just a moral conviction. You needed training. And so after my residency, actually, when I was a resident, my residency director pulled me aside and said, "John, what are you doing with your life?" And I'm like, I don't know. I thought maybe cardiology, but I don't think it's for me. And she said, "Have you heard of the General Internal Medicine Fellowship?" I said, "I have no idea what that means. What are you what's health services research? What's GIM fellowship?" And it turns out it's a 2-year program where you get training in health services research, you get a master's in public health, you get mentorship, and the idea is to churn out independent clinician investigators who are general internists. So I didn't know that was a thing. I thought research was for basic scientists who were specialists. Didn't know that general internists could be federally funded investigators, but we can. And that's the idea of the GIM fellowship. And so that is really the difference maker, because it gives you rigorous training in terms of how to measure the quality of care, how to measure value, and how to improve quality. And so that's really, really important set of skills that you need. And we've been able, this is not just me, this is a group, a team of scientists, of investigators and collaborators. We've been able to publish some work that has informed policy in this whole space on how to improve value in our health system. And I'm going to really talk about mainly one of these projects today and kind of go a little deeper. But we've gotten funding, as you heard, from NIA, Arnold Ventures, to look at these different sort of areas of assessing the value of care. But none of this would have been possible without mentorship, without my program director pulling me aside and saying, you really need to think about a general internal medicine fellowship, which I hadn't heard of. I hadn't heard of health services research. And I didn't know that general internists could be leaders in research. I didn't know they could be federally funded. So that is all about having the right mentorship and training. And I've been very fortunate, even at UCLA, to have some amazing mentors as well. So that's sort of a little bit about how I got here. And now I'm going to give you a little bit more background into understanding exactly what we mean by low value care a little more precisely, why it's important a little more. And then in the second half of the discussion, to really look at some real world strategies to improve value within health systems. And I'm hopefully going to leave plenty of time for discussion, because I really do welcome your thoughts and your questions. But now to get down to some business. So we got to define the terms. What do we mean by value? And there are many different ways people talk about value. And the way that most people, when they talk about improving the value of healthcare, most of the time, what they probably mean is either improving health outcomes and keeping costs constant, or keeping health outcomes constant and lowering the cost. So that's sort of the two ways that you can achieve value, or both, improving health outcomes at a lower cost. I mean, that's the dream. Of course, that's very rare, but that's the basic idea of what people mean when they talk about value. What kind of health outcomes, health status, quality of life, survival, hospitalization. There's many different ways to measure health and health outcomes. But when you talk about costs, we're going to get to that in a bit, but it's important to define that too. And when I talk about low value care, I'm really saying that purely on a clinical framework, the probability of benefit is not higher than the probability of harm. Either it's a wash, or the harm is even more likely than the benefit. So an example of that, perfect example of that, is a routine antibiotic for the common cold that's caused by a virus. Patient has the sniffles for a couple of days, no red flag features, good immune system, young and healthy, gets an antibiotic. That's the perfect example. And antibiotics, every 1 in 1,000 of these, they'll kill your microbiome. They could lead to an ER visit 1 in every 1,000 times. That's a perfect example of a low value service. But there's different ways to talk about low value care. This is the clinician's definition, my definition of low value care, but it's a pretty narrow definition, because most care is not this. This is maybe 10%, at most 20%, probably closer to 10% of all care that we deliver in the US is low value. So it's not the majority, okay? Don't feel too bad. But there's different ways of measuring value, and the economists or policymakers, they measure value differently. They talk about, is the care cost effective? So how much are you willing to spend to improve a certain quantity of health? Okay. And the most common one that's used is called the quality. It's the quality adjusted life year. And basically it's how much do you have to spend to give a person an additional year of disability-free life? And typically in Europe, it's like they arbitrarily put it at like $30,000 or something, or $50,000. But in the US, it's like $100,000. But there's a lot more care that encompasses this definition. This is a much broader definition. This is the definition that, like, say, a cancer drug will give you 1 month more of life on average, but it costs $1 million. That is not low value from a clinical perspective, because there's a net benefit. You get a month of survival, but it's from a cost-effective perspective may not be a high-value drug. So that's why it's really important to define your terms. So for today's talk, I'm mainly going to be talking about the first definition. When I'm talking about low-value care today, I'm going to be talking about the low-value care that is clinically is not beneficial on net. Okay. But I just want you to keep in mind, there's a broader definition out there from the policymakers, and you know, and we can get into that in the Q&A. And then when you talk about costs, you always want to ask costs to whom? Is it costs to the patient? Is it cost to the insurance company? Is it cost to Medicare? Is it cost to society? Is it cost to the health system? You always need to clarify that, because if you look at it in any different way, it's going to be a different answer, right? So that's really, really important. And, you know, but generally, you know, price times quantity is sort of the very basic approach to it, but that's also really important to understand. So I want to now give you a little bit of a history lesson. I love history, as we talked about last night. And my wife here, who knows very well, who I bore all the time. But they're actually low value care or inappropriate care that's potentially harmful is not a new thing. We've been providing low value care for millennia. One of the quintessential examples of this is bloodletting, which comes from humoral theory, and trying to, you know, fix the imbalance of evil humors, dating back to the time of, you know, the ancient Greece. And of course, you know, by the time we get to the 20th century, we have breakthroughs like antibiotics and radiology and all kinds of, you know, new scientific discoveries that ultimately, germ theory, all these things that really eliminated a lot of low value treatments, actually. But turns out looking at inappropriate care systematically only recently was started. The first time it was ever done was by Rand in the 1980s, when they developed the UCLA Rand appropriateness criteria, pioneered by Bob Brook and Catherine Kahn and many others. And so it turns out that, you know, when these criteria, again, they're clinical criteria, they're looking at net benefit versus net harm. You know what's crazy is that shockingly, the United Kingdom, which has a national health service, versus the United States, which has sort of a mixed market service and of course a fragmented system and no nationalized health insurance, they actually had similar amounts of inappropriate care. So the volume of care was very different. There was just per capita, there was less care overall. But when you actually studied the medical record and you tried to do a medical record review, the proportion of inappropriate services in the UK was actually similar to the United States, and in some instances higher. And this was very, very surprising. But what it demonstrated was a really, really important point, that if you use blunt financial policies to just tamp down on volume of care, it does not equate to better appropriateness of care. All it does is it just reduces the total volume of care, but the proportion of inappropriate care is the same. Does that make sense? That's a really important point, because it's possible that in the next 10 years, we could be entering a new era where there's huge clampdowns of utilization. And what we don't want to be in a position is that we're reducing all the care together, the inappropriate with the appropriate. That's not what we want to do. So that's a really important point, and that's been repeated in the literature over and over. If you use these blunt policies, what it does is it reduces all care. That's a really, really important point. And so, yeah. Oh, thanks. Oh, can you guys see my my pointer? That actually makes it easier. Thank you. All good. So now, where do health outcomes come into play with low value care? So it doesn't directly, so appropriateness has to do with the outcomes, but not through the costs. The important point to note, when I talk about low value care from a clinical definition, it's not rationing. So what is rationing? It's when you're trying to not give care to somebody because it's too expensive. You don't have the money. That's rationing. When you're defining low value care purely from a clinical standpoint, it's not rationing. You're literally saying this is poor quality care. This is not going to benefit you. You shouldn't get it. Not because it's too expensive, but because it's going to potentially harm you or not benefit you. So that's really important point, distinction. It goes back to the definition, but it has everything to do with value, because low value care is not going to improve the outcomes, but it's just going to raise the cost. So you deliver a care that has no net benefit, the outcomes won't change, but the cost will go up. So the value will go down. Does that make sense? And the way Rand defined it was basically like taking it, like look at the antibiotic. They're used every day. They're life-saving. So somebody who has a bacterial pneumonia or is septic, antibiotic is life-saving. Sooner the better. And that's called medically appropriate. In fact, that should be called sort of stronger medically necessary care, right? That's not the kind of stuff we want to be limiting. That's the stuff we're underusing, actually, these antibiotics for patients with pneumonia. That's the good stuff. And that's like 80 to 90% actually of the care we deliver. Equivocal care is like when it's a wash, you're on the gray zone, because technically the IDSA guidelines say you can give an antibiotic if it's 10 days of sinusitis, maybe even 7 days, so somebody's on like the 9-day track. It's kind of maybe a benefit, maybe a harm, but it's kind of a wash. That's called equivocal care. And then inappropriate care is the care where there's frankly is going to be a net harm, that the antibiotic is going to cause more likely to cause harm than good. And that's somebody with the sniffles for a couple of days and no red flags or anything like that. And it's, frankly, the patient harm angle is a wonderful way to try to explain to your patient why this, after a thorough physical exam and thorough evaluation and really listening to the concerns, you can provide a lot of reassurance and counsel your patient that this is going to be much more likely to cause you harm, diarrhea, rash, and a lot of other things. So that's a great way to counsel your patients on why an inappropriate test may not be indicated. But the key thing is you don't want to just dismiss up front. You need to do your due diligence. You need to listen to the complaint, and you need to do a very thorough physical exam, tap on the sinuses, listen to the lungs, and make that decision only after that. The critique of this RAND approach of purely clinical benefit is that it excludes cost ineffective therapies. There's a much broader bucket of services that provide no benefit, that provide minimal benefit and are very expensive. And our group has studied some of those therapies too. We talked about it earlier today. Those are called cost ineffective. And the problem with this approach is it's a very narrow, it's like I said, about 10% of care maybe. And so you're excluding a much bigger bucket of low value care from the economic perspective, where you're getting little marginal benefit, but very expensive. Okay, so that's the Leqembi, is a perfect example, the Alzheimer's drug we talked about. Why is it important from a policy why are policymakers interested in low value care? I mean, as a physician, I'm interested in low value care because it harms patients. From a policy perspective, the payers like Medicare, the commercial payers, they need to keep premiums low, and they need to actually have enough money to cover the claims for all of the services that our patients are receiving. And in order to do that, they need money. And unfortunately, Medicare is running out of money. And the latest projections are within a few years, Medicare Part A is going to be out of its reserves. And it would need an act of Congress to sort of replenish that. So there's, but at the same time, there are massive inequities. There's millions of Americans who still don't have insurance. And there's so many patients who aren't getting life-saving drugs like hypertension drugs, diabetes drugs, SGLT2 inhibitors. There's all this demand for really high value care that's not being delivered, and it's not being delivered equitably. But how are we going to pay for all this when we have a huge budget problem? That's the idea, is there's a lot of wasted money on these low value services that don't actually benefit patients and actually cause harm. That if we were to reduce these services, the idea is that you would make financial headroom so that you could expand access to high value therapies. That's the idea, that if you save that money, you give it back to the patients through expanding access to care equitably. So that's sort of the appeal. there's a lot more bang for the buck. So in summary, I hope I convinced you that low value care is timeless, it's costly, it's ubiquitous, and it's potentially harmful to our patients directly. This risk of harm is a central moral underpinning of all of why this whole work is really important. And, our work, but a lot of others' work has highlighted that there are many areas of low value care that you as physicians can lead in your own health systems to tackle and to reduce. Anybody know who said that? That's a good guess. That's a good guess. That's a good guess. Others? Hippocrates. Good job. That's right. This is part of the Hippocratic Oath. And you know what? Back in ancient Greece, there were snake oil salesmen. There were folks who didn't have the right credentials. And Hippocrates was warning to avoid the doctors who are willing to give you these toxic poisons to treat your disease. And that's the number one moral requirement of a physician, is to do no harm. And that's why it's built into the Hippocratic Oath. It's actually not clear that he wrote that, but it's who it's attributed to. So now I'm going to introduce some strategies to improve value. So we're going to start from the high level, from Washington, D.C. How do policymakers think about improving value? Because this has been talked about for decades. Ever since actually early 20th century, we've been thinking about how to improve value even in the US. And if you go back to this equation, the way policymakers are focused on value is two ways: price and use. Price and quantity. That's the two types of ways. Now, price, we're not going to talk about as much today, but that's a big one. In fact, price is actually the real reason why health spending in the US is 2 to 3 times that of Europe and other industrialized nations. It's the price. It's the price of pharmaceuticals, and it's the price of big health systems. And so that is, that's what this new legislation, the Inflation Reduction Act, is going to try to address. But the other way is utilization. How do you control utilization? So if you think of physicians as controlling the supply, and you think of patients as driving the demand for care, there's different ways that policies are designed to sort of limit that. And on the supply side, policymakers have created these complex payment programs where the key point is this: for thousands of years, physicians have been paid on a very simple fee-for-service metric. You provide a service, you get a payment for that service, and the physician will generally set their own rate privately. Now, Medicare took that on in 1965 when Medicare was established, and they continued that tradition, and they provided a physician fee schedule. They set the rate, and then physicians, the more they would do, the more they get paid. And the idea is that this is going to potentially encourage overutilization. And so Medicare tried to change the incentives over the decades, trying to do new innovative payment models to try to tamp down on this overutilization. And one of the ways that they did that was that instead of paying the doctor for each service they delivered, they paid by patient, capitation, by the head. So you count head count of how many patients you have, and you give a per member per month or annual amount of patients for your population. And if the physicians order more services, they're at risk. They might have to pay for it because they exceed a certain amount of budget. They're not getting paid for service anymore. That's the idea of value-based care, basically, in a nutshell, is to change the financial incentives so as not to encourage overutilization, but instead is to encourage high-value care. That's the idea anyway. And so that comes through the latest iteration is accountable care organizations, ACOs, bundled payments. And basically bundled payments, instead of paying per patient, you're paying per episode of care. And then, these have had some mixed results. They have reduced spending in the experiments that we've seen in health, and they've reduced spending maybe about by 1 to 2% total spend. They've improved quality a little bit, but no dramatic panacea. with this. On the patient side, it's a lot more fraught. The cost sharing, unfortunately, is effective. But it's unfortunate because what cost sharing does, that means the patients have to pay more and more out of pocket to disincentivize the patient from seeking care. The problem with this approach is what I already taught you, which is that whenever you try to do a blunt instrument to try to tamp down on utilization, especially on the patient side, the patient will reduce all care. They'll reduce the life-saving care just as much as they'll reduce the low-value care. And that's really harmful. And that's actually disproportionately affects racial and ethnic minority groups and patients who live in poverty. So that's a really big problem that drives inequities. Unfortunately, the insurance companies are increasingly using these. They're not using them less, they're using them more. And high deductible basically means that you as the patient basically for almost all care have to pay the full price of a service until you meet that maximum deductible. High deductible could be a few $1,000s a year. So, and this has led to a lot of financial toxicity. So it works in tamping down utilization, but it has a lot of side effects, and it's a very blunt tool that is not designed to target low value care at all. So that's the current state of health policy in trying to improve value in our health system. And when you're at the macro level, it's really hard to be clinically nuanced. That's the key lesson here. And there's a lot of side effects from some of these things, especially on the patient side. What are other strategies that we're trying to do to improve value? Well, it's the publication of guidelines, best practice guidelines, randomized controlled trials. This is the evidence-based medicine. This is the stuff that should be influencing policy and practice. And, you know, the perfect, I mean, sometimes it works. Sometimes it works, but a lot of times it doesn't work. And I'm going to show you a case here. And this is a big New England Journal article from 2000, the value of routine preoperative medical testing, where patients were so cataract surgery is one of the most low risk surgeries out there. It's 15 minutes, your local anesthetic, very low risk of adverse events, but we basically have always done chest x-rays, EKGs, laboratory tests for every patient who's undergoing these procedures. So they did a randomized trial 24 years ago, and they proved that basically these routine preoperative tests did nothing to improve health outcomes. And they measured it in multiple different ways. And ultimately, practice for that 10 years later, they looked to see if that actually changed practice, and it didn't. So people are still routinely ordering these preoperative EKGs, chest x-rays, labs, sort of reflexively for patients who are undergoing cataract surgery. And the idea there, unfortunately, guys, is that evidence and guidelines, they're mostly, there's some exceptions, but they're mostly insufficient in changing behavior and reducing low value care. That's the harsh truth. There needs to be more. Okay, so this is just another example of a study we did a few years ago where we showed that there have been so many guidelines over the past few decades emphasizing that back pain is a very self-limited condition. As long as there are no red flags, immunosuppression, neurologic deficit, fever, fall trauma, as long as those are absent, most back pains, 90–95% of the time, they'll resolve on their own, and they need very conservative management. What we showed, though, was in the past decade, all of the wrong treatments were increasing, like opioids and referrals to neurosurgeons and specialists were going up. And the first-line therapies, like physical therapy, which actually have some evidence of benefit, didn't change. And then the NSAIDs and acetaminophen were actually declining. Those were considered more first-line than opioids. And so ultimately, everything, despite the guidelines, were going in the opposite direction the guidelines were saying. So this was a study that kind of underscores that point, that unfortunately, guidelines and evidence are not enough. So what is enough? What else do you need? What's missing here besides evidence and evidence? Well, these authors in a paper from JAMA looked at what works, and it turns out this is what they argue. You need economics. So that's the key missing piece. So you need evidence first. The evidence shows that something is ineffective. Okay. You need eminence, meaning you need to have your major society guidelines say, yeah, we agree. American Orthopedic Society agrees that, knee arthroscopies are ineffective for, patients with meniscal injury compared to physical therapy. But you also need economics. And when you have all three of these align, that's when you start to see action. That's when you start to see differences. But it turns out that there's a huge range to economic levers. Okay. So the details really matter. You could go from like light economic levers, like capitation is what I mentioned before, where you're not really micromanaging any condition. You're just kind of telling the doctor, okay, you have a practice of 10,000 patients. We'll give you X dollars per month per patient. And then you have to manage their care as cost effectively and efficiently as you can. And if you spend too much, you have to pay for it. And so that's capitation. It's a lighter form of this economic incentive. There's some really stronger economic levers. Prior authorization. That's a dreaded word as a physician, because it's often red tape and it's often blocking a lot of medically necessary care. It drives me crazy, but it actually works. And there was a study out of Humana that showed that actually 90% of prior auths are eventually bypassed eventually. You just have to submit the paperwork, and they're not, a lot of times, not even clinically, they're just putting roadblocks for whatever's expensive. And it works. It's very blunt though, very blunt. It'll block life-saving care. It'll delay life-saving care. So but it's more effective. The most extreme, what is the most extreme? Insurance says, we're not paying for it. We're not paying for it. That's the most extreme economic lever. And we saw that last year with Aduhelm, the Alzheimer's drug. Medicare said, we're not paying for it. It's too unsafe. And so, that's the range, and it's tough out there. And there's a lot of these barriers. The limits of this framework, it can, be a little bit oversimplistic. There's a lot of factors like organizational culture, but they did talk about this really interesting example. And so there's a quintessential low value service, which is vitamin D screening. So of course, if somebody's got chronic kidney disease, if they have osteoporosis, if they have a pathologic fracture, if they have hypercalcemia, absolutely, you should be ordering. We're probably not ordering enough vitamin Ds on those patients. But what this is saying is, for a patient who doesn't have a lot of the clinical indications, you're just doing a routine reflexive vitamin D. Those have been shown not to be beneficial. There was a big randomized trial in the New England Journal last year that showed routine vitamin D screening and treating for older adults doesn't improve outcomes, fractures, anything, osteoporosis, and nothing. So that's why it's really not recommended for reflexive routine screening. Certainly, if there's risk factors, you should do it. So this study showed that it's the evidence, eminence, and economics. So I want to orient you to this figure here. On the y-axis, you have the number of tests per 100 visits. On the x-axis, you have time. And in the blue, you have Canada, where they stopped paying for the vitamin D. And then in the orange, you have the commercial, US commercial payer claims database. And then in the gray, you have the veterans. And as soon as Canada stopped paying for the vitamin D after recommending that it wasn't recommended, you have the specialty society saying it wasn't recommended routinely, the rates dramatically declined compared to the control. And they did another control group looking at T3 levels, which are typically not recommended. And there was no payment change there, and there was no effect there. So that's an example of sort of evidence, eminence, and economics. This is a really extreme measure. This is a really extreme approach. I have very, very mixed feelings about it. And this might be where we're headed. This might be where we're headed, with payers just refusing to pay. It just came out last week that United Health was going to put prior authorizations on all colonoscopies and endoscopies, all of them. And we know that many of these are life-saving for working up GI bleed. But there is another way. So they actually backtracked. They said, okay, we're not going to do because there was a big pushback from the GI community. So fortunately, but they did still put other barriers in place, and it's still being worked out. There is another way. There is another way, and it can be physician led. It could be local QI, and it can be done. It can be done. And I think as physicians, we should do this ourselves before we lose the ability to do it ourselves. So this is sort of the meat of the talk, which is reducing low value preoperative testing for patients with cataract surgery. As I mentioned, it's reflexive, it's low value. And at LA County Medical Center, which is the county system in Los Angeles, it actually in that system, it's actually capitated. They don't make a profit by ordering more tests because their money comes from the state of California, but yet it occurred more than 90% of the time, these preoperative tests for cataract surgery, and basically increased the surgical wait time. So our research team got a Choosing Wisely grant to study about an intervention to reduce low-value preoperative testing for patients undergoing cataract surgery at one of the largest safety net health systems in the U.S. And here is the work of an amazing QI nurse who, in the lower left corner here, began with the data, always begin with the data. She reviewed patients' charts and looked at dozens of cases of patients who were getting all these reflective tests. They did no good for the patients. They led to delays in care, unnecessary referrals. She presented that data to the clinical chiefs. She was being backed by the chief quality officer. So you got to have leadership backing you and present. And with their backing, started an informal education process of all of the residents, the ophthalmology residents, the anesthesiology residents. They got a chief resident to rewrite the guidelines. She collaborated with the nurses. So every level of stakeholders she collaborated with, and they changed the guidelines. They changed they stopped scheduling the routine preoperative visits. And then they announced in 2015 that we were totally changing the guidelines. No more routine preoperative visits and testing for these low-risk patients. And then she monitored the effect, using PDSA cycles, Plan, Do, Study, Act. And basically that was her intervention. And we were just along for the ride. She was engaging physicians through appeals to evidence and professionalism. And our role as a research team from UCLA was to assess the effect of this intervention. And we looked at all the preoperative tests. We also looked at adverse events and safety. We did a difference in differences analysis. And then we did a cost analysis from the LA County perspective, but we also did a cost analysis from the perspective of a fee-for-service health system such as UCLA or UCSD. Because remember, in LA County, because they're capitated, if they order less tests, they save money. But if UCLA orders less tests because they're paid per service, they lose money. Does that make sense? If they order less tests. So depending on your financial model, reducing low value care will either save you money or you'll lose money. So we looked at it in different ways. So the results were about 1,000 patients in each arm, 61 years of age, 53% female. And I want to show you in these figures, this is time on the x-axis. On the y-axis is the percentage of patients who received a medical visit, preoperative medical visit, preoperative x-ray, preoperative labs, and preoperative EKGs in these 4 panels. And the orange is the intervention site, LA County USC Medical Center. Now it's called LA County Medical Center. And then blue is Harbor UCLA, the control county hospital, where they didn't do the intervention. And what you could see is that medical visits declined dramatically, but then they rebounded back up. And I'm going to tell you about why that happened in a minute. But preoperative chest x-rays dramatically declined compared to control. And same thing with lab testing and EKGs. But notice that none of the levels actually got to 0. So that's really important. There are still plenty of circumstances where sometimes these are indicated if somebody has chest pain. And actually, importantly, Patricia Godoy, Dr. Travieso, she got her doctorate recently. She checked every medical record. She looked, there were no upticks in perioperative adverse events, and there was no withholding of high value necessary care. So if a patient had chest pain, they were not prohibited from getting an EKG. Patients who had kidney disease got potassium checks, et cetera. So that was no safety, no harm or no safety signal there, fortunately. And then finally, sort of the last piece of this whole thing is how much did it all cost? Okay, so I'm going to try to walk you through this cost analysis. So I want to show you here on this column are the inputs and outputs of cost. So investments, that's how much LA County USC paid to get this intervention done. And then this is how much they saved potentially on reducing the care. And this DHS, that means Department of Health Services, that's basically the LA County perspective. And so we looked at every input and output to get a final answer. And then we also looked at the different hypothetical perspectives. Like if this would have happened at UCLA, they would have probably lost more money because they lose a profit on ordering less services because they're a fee-for-service system. And then we looked at the perspective from society. The bottom line is that there were big investment costs. They had to pay for Dr. Travieso's time where she got QI training. She had to spend 20% of her time on the project. And ultimately in year one, LA County lost money. And even though the incentives aligned perfectly, they lost money because of the big investment cost. But by year three, they saved a modest amount. UCLA fee-for-service health system, they would have lost money in year one and they would have lost money in year three. A fee-for-service health system has no financial incentive to reduce low-value care. That's a really important point. Society gained the most because basically people didn't have to miss work for their labs. So that was wages got back into the system for societal savings. And so society had the biggest benefit. This intervention also freed 70% of a licensed vocational nurse's time. Limitations to this study are important to take note of. This was non-randomized. This was a multi-component intervention, not a single component. This was a single large safety net health system. So you have to also wonder about generalizability. And we didn't incorporate care cascades. What's care cascade? You get an EKG. It shows an abnormality that's benign, but it requires a cardiology consult. That's an extra cost. We didn't incorporate that. We were trying to be conservative. So in conclusion, at this large safety net health system, this QI initiative substantially reduced low-value preoperative care for patients undergoing cataract surgery. It saved costs for the health system. Fortunately, there was no uptick in postoperative adverse events. That's super important. You saw that the medical visits bounced back to baseline. You know why? Patients were missing their phone calls. They were arriving late and unprepared to the procedures. And so we realized that the in-person visits were actually super important in providing critical patient education. And so those were resumed, and that was only because Dr. Travieso was monitoring the intervention very carefully. And the other important point is that patients in the safety net are particularly vulnerable to unintended consequences of QI interventions. The bottom line, all QI initiatives, especially when you're providing less care, you're reducing the care, they require very careful monitoring for unintended consequences. What are the financial implications? Reducing low-value care, it saved a modest amount for any kind of financially capitated system like LA County. But there were losses for fee-for-service systems. There's a reason why UCLA hasn't said, "Hey, John, we want you to reduce all preoperative, procedures at UCLA." Well, they lose money, so that's a big barrier, and we proved it. And basically, LAC could have saved more money firing an LVN, but they didn't because there was a great need for staffing. And, ultimately all projects, even when the financial incentives align, even when you can save money reducing unnecessary care, you saw it took a massive effort and a massive investment of resources to achieve it. And despite the alignment of evidence economics, you need a catalyst at the health system level to really drive this change. I've been lucky to study, we're actually looking at a big catalyst of an effort to reduce low-value care across the state of Virginia. It's a $2.3 million Arnold Ventures grant, and we're actually trying to apply some of these methods at the state level. We're going to see if it works. More on that soon. If you're at a health system, you're a QI leader, you really need to look for the win-wins. And what's an example of a win-win? So there's a lot of underuse of colon cancer screening. So we're trying to convince the GI leadership to reduce low value cancer screening so that we can make headroom for the underuse of high value colon cancer screening. So that's the way you can appeal to health system leaders. There's other areas where there's clear patient safety signals like antipsychotics, where it doesn't even matter what the cost is. You just need to stop delivering it because of the toxicities for patients. And this could be the future of us. We've been talking about it for years and there hasn't really been a big shift. Honestly, what the studies show is that a health system needs to have about 60 to 65% of its patient pool be capitated in order to make big moves towards value-based care. And right now, UCLA is like about 30 to 40% capitated. So they're not incentivized enough. Most of their money comes from fee for service. So they're not going to be incentivized to reduce the low value care if most of their revenue is coming in from doing more. So unless the payers are trying to push the health systems to more and more join these alternative contracts and more that are at risk, where a health system might start to become incentivized. And that magic number seems to be around 63% of your patient population being in an alternative payment model that's at risk. That seems to be the number. We wrote a paper on a 10-step program to reduce low value care in your health system that we published in AJMC. Key thing, you need buy-in from leadership. You need multidisciplinary efforts, and you need to have respectful and non-judgmental language when you're trying to give feedback to different physicians. And you need physician champions. So take-home points: low value care is timeless, it's ubiquitous, it's costly, potentially harmful. Reducing the risk of patient harm is a central moral underpinning of why this work is important. Evidence and guidelines and even capitated payment, it's necessary, but it's insufficient by itself. You still need, at the health system level, you need a catalyst, a financial resource investment to drive this change. But the other future I'm telling you about the prior auths and the non-coverage, we can avoid that future if we as physicians take the lead and start to reduce low value care that's clinically responsible and safe and is clinically nuanced. We just need investment from leadership and time and resources to do it. So I just want to acknowledge an amazing multidisciplinary team, my mentors, Catherine Sarkeesian, Cheryl Damberg, and an amazing host of people at UCLA and beyond. So thank you for your attention and time, and happy to take questions.
Yeah, thank you so much, Dr. Mafi. It's really an economic ride. I mean, it's extremely expensive to die in a society today, and we need to make it dignified and costly, but concentrating on the living. So it's really where medicine meets politics here, if we're going to survive. And you certainly are a front figure in that debate. So thank you so much. The forum is open for questions. We have a microphone, so please, and also it's open for chat questions.
Thank you so much. That was really interesting and very thought-provoking. I was just wondering how you go about having those conversations with patients. You know, they sometimes will come into clinic and they have a test in mind that they want ordered. And kind of how do you balance maintaining rapport with kind of not ordering those low value tests?
Yeah, that's a wonderful question that it's a challenge for me, and it's a challenge for all of us. It's not an easy task. I think that the number one thing you can do as a physician is to, first of all, be a good listener. So when somebody's coming in and they want an antibiotic or they want an MRI because they're concerned about their neck pain or they're concerned about their runny nose or their cold, you want to keep an open mind, but not just externally, internally, because you have to tell yourself, don't miss that serious case. Don't dismiss it. Listen to it. Listen and listen to that voice and do a thorough exam. So ask them all the right questions, red flag questions. Ask if they have upper respiratory symptoms, make sure they're not having shortness of breath, make sure that they're not having fevers, and make sure they're not immunosuppressed, they don't have lung disease, they don't have other risk factors, and look at the time course and think about the guidelines. You need to tap on their sinuses, you look in their ears, you look at their throat, the center criteria, IDSA guidelines, listen to their lungs. And after all that, you're being very positive. You're being reassured, hey, this is great. Your exam is reassuring. I don't see any evidence of sinusitis. I don't see any evidence of a strep infection of the throat. I don't see any evidence of a pneumonia. I think you're going to be fine. This is great news. And 9 times out of 10, after a very thorough exam, most patients will be reassured. I will say it really helps when you have a continuity relationship. This is much, much harder to do when you don't know the patient because they don't trust you. That's only natural. So you have to earn that trust very, very quickly by being an open-minded listener, taking their complaints seriously, having a thorough history and physical exam to provide that reassurance. And, so that's, it doesn't always work though. It's really, really hard. And I've had some awkward situations where if it's a gray, like you're on day 8, some guidelines say 7. I mean, you can maybe, if they're really pushing and it's not wrong, you could consider offering it if they really feel strongly. But if it's a clear no, I've had some pretty tough situations where I said, I just don't think it's right because I'm worried that I'm going to cause you direct harm. I don't feel responsible offering this test because I think it's going to cause you harm. And you can say that. And you want to say it in that way because it's not about the money. I wouldn't, there's no money incentive for me to order this test or to give you this antibiotic. It's really about harm for the patient. And if they believe you, most of the time they'll be reassured. So a lot of time people think that they're there for an antibiotic, but a lot of time when you survey patients, that's English speaking and Spanish speaking patients often just want reassurance. And you can give that reassurance with a good history and physical exam. Mm-hmm.
Thanks. That was very interesting. So you sort of alluded to the fact that physicians haven't led very well in taking this on. So a lot is reactive, right? We get dealt whoever centrally decides. At what level do you think we should be undertaking this? Is it at a state level? Is it a local level? How do we actually organize ourselves to do this rather than waiting to see what comes down from Washington? Because you obviously had local success, you got funding, you did it, but that relies on local advocacy, resources, things like that. It's very disheartening when you show that a health system actually loses money when you stop these things. So you almost have an adversarial thing going on in a triangulated way between the patient, the physician, and the health system. So how do we make this happen on a much larger level?
Yeah, that's an amazing question that, I think that's sort of the, one of the main thrusts of sort of my whole career is trying to answer that question. And what I can tell you is that the first thing that we can do as physicians is to educate the public and to be leaders, to be vocal leaders about the public. And I think that, having success stories that are published is great, but I think that physicians can do a lot better job of advocating and getting in front of policymakers, getting in front of lawmakers to really advocate for what it takes to improve quality and value that's in a way that's safe. And that's as a researcher, it's actually super, super important to get your work in front of policymakers because they sometimes do listen. And if you can show that some of these policies are actually harming our patients through your work, like prior authorizations and things like that, policymakers will be more likely to listen. And in fact, they are. So for the first time, Congress is starting to crack down. The federal government is starting to crack down on Medicare Advantage prior authorizations, because there's been some exposés in the New York Times and others where these are causing patients harm. They're delaying life-saving care. And so getting the work out in the open and in front of policymakers is number one. But as far as working towards a national solution, it really has to be at every single level. It has to be at the national level, it has to be at the state level, and it has to be at the regional level and at the health system level. And they all should be coordinated. Who should be leading that? I mean, I don't know who exactly. I think the American Medical Association is one possible candidate to do that. But before you can get a bunch of physicians and health systems to want to do this change, there does need to be that economic piece. So I don't know if you're familiar with Peter Pronovost. He's one of the sort of founders of the patient safety movement. He's somebody who's actually been able to get this done at the regional and at the national level. And he got payers, he convinced payers, you should study his career. He convinced payers to put resources and money into QI. And he showed first through the data that things like central line infections were preventable and deadly. And he got the payers to basically pay for big QI programs that were physician-led at the health system level. And he not only reduced the mortality rates from central line infections, but he saved the payers money. It was a win-win-win. And that's exactly the kind of model that we need, I think, taken to a bigger scale. Obviously a lot easier said than done. So we have some work to do. I hope that you all, as the next generation, take that on, because we need smart leaders in this space more than anything. And so I'm hopeful that you'll come and help us.
Thank you so much. We have prioritized questions from the audience here present live. There is a couple of questions in the chat. Do we have time for that? Just one. Does the fear of litigation still play a role in the ordering of unnecessary tests and treatments?
Yes, it absolutely does. It's a real challenge, and that's often cited as a reason for why unnecessary care is delivered. If you look at the evidence, though, it turns out that ordering tests objectively is not associated with lawsuits at all. You know what is? What's the strongest predictor of a physician getting a lawsuit? Does anybody know? Yes, the communication and the relationship. That's the number one predictor. If you're a poor communicator, if you're not engaged with the patient and not being, not dismissing their concerns, and you're open in your communication, you're much less likely to get a lawsuit. Ordering a bunch of tests doesn't protect you from a lawsuit. So there is a reason why there's fear about it. But if you're following the evidence, if you have a strong relationship with your patient, a trusting relationship, if you're doing a very thorough history and physical exam, and you're very good about your documentation, and you're very good about your communication, and you're very good about even documenting, that you had these conversations, you're going to be fine. And that's the truth. That's from the evidence, that, and they've looked at, they've looked at, ordering a bunch of tests. It doesn't help you. So that's the point about that. It's a great question. And I do think that there still needs to be some reform, tort reform, where basically, they should be physicians should be given immunity if they follow the guidelines that's an important, tort reform. But I just want to say that the much stronger variable here is your relationship with your patient and how you communicate with your patient. So that's key.
I think we're going to end on that positive note. Is the relationship between patient and the doctor. That's value, and it's money in that. So thank you so much for coming to us, and we invite you again. Thank you.
Thank you. Thank you so much. Thank you.
Yes, we have a couple of announcements, really important announcements.
Thank you so much. It's my pleasure to announce the winner of our resident research. And we're really fortunate that every year, nearly 40 of our residents have the opportunity to participate in a 2-month research block, thanks to the support of the Department of Medicine. They present their research at a research symposium that we have in the spring, and then 4 residents are selected to present their research at Department of Medicine Grand Rounds. Today, it's my pleasure to honor Dr. David Hibbert for the work that he presented at Grand Rounds last week. He's being presented with the Outstanding Resident Research Award. Congratulations, David. Yeah. Thank you.